Moving on to seizures, a 17-year-old female soccer player suddenly collapses on the sideline and has a transient episode of shaking. She's confused for a few minutes after the episode. She's taken to a local emergency room for evaluation. Vitals and an ECG are normal. She then has a second episode of altered consciousness in which her eyes are noted to roll to the right, followed by convulsions of the arms and legs, and continues for several minutes. Which is the most appropriate next step? A non-contrast head CT, a lumbar puncture, an electroencephalogram or EEG, intravenous lorazepam at 0.1 milligrams per kilogram, or intravenous tissue plasminogen activator. The best possible answer here, this patient has had now 2 witnessed episodes and is currently seizing in the emergency room. So the best option for the immediate step is IV lorazepam. As you look at the other answer options, many of them are appropriate, but the first step is to stop the seizure. So this patient is in status epilepticus. She's having several minutes of ongoing seizure activity. She's not returning to baseline. So the number one goal is to stop the seizure. The diagnostic tests, including the imaging, potentially the lumbar puncture, and EEG are all appropriate, but the seizure should be stopped first because irreversible brain injury can occur within about 30 minutes. TPA is indicated for acute stroke, which does not seem to be the case for this 17-year-old patient. Seizures are paroxysmal events in which the brain becomes electrically overactive and there's a gain of function. Status epilepticus is ongoing seizure activity more than 5 minutes without full recovery of consciousness. It is a neurologic emergency as irreversible brain injury can occur within the first 30 minutes. For status epilepticus, a key point is that treat the seizure first. We want to stop the seizure before we proceed with testing. The testing that can be appropriate once the seizure is stopped, and EEG is considered routine. Important point for EEGs is they can miss some seizures, as the brainwave activity can be normal in between events. So if there's a high index of suspicion, you can consider longer-term EEGs or video EEG monitoring. Imaging should be considered routine, ideal in MRI scan, again, only once the patient has been stabilized. Lab testing, including spinal fluid analysis, may be helpful. If there's a suspicion for an infection, it's mandatory. But for a patient who's had a simple seizure, CSF analysis is not required unless you feel there's some clinical indication. Seizure should be considered a diagnosis in any patient with recurrent neurologic episodes or unexplained loss of consciousness. In terms of treatment, a status epilepticus needs to be treated immediately. Well, I would not expect the board to ask you a great deal of all the different antiepileptic medications. The basic management of status epilepticus is probably fair game. So following the current guidelines, the first-line therapy for status epilepticus is lorazepam, 0.1 milligrams per kilogram. Other medications are commonly used in different clinical practice, but in terms of test taking following guidelines, lorazepam, 0.1 mg per kg would be first line. Additional options are phenytoin or a fosphenytoin equivalent at 10 to 20 mg per kg. And now levetiracetam is indicated for status epilepticus at 1,000 to 3,000 milligrams in terms of a loading dose. Epilepsy is the risk for recurrent unprovoked seizures. So a single seizure with no evidence of recurrent risk does not require treatment. Sort of simple saying, the first seizure is for free. Any brain has the capability of seizing. The question is the brain at risk for recurrent unprovoked seizures. If there are recurrent events or high risk of a recurrence based on the history or objective testing, an anti-epileptic drug can be started. So if a patient's had a single seizure, you have the option to treat them, particularly if you think they're high risk. Something in the brain MRI is abnormal or the EEG is abnormal. So you can treat after the first seizure. There are no guidelines as to which anti-epileptic drug to start. Few adult epilepsies are responsive to very specific therapies, so the decision about which anti-epileptic to start can be based on a number of factors, including other medical conditions, other side effect concerns, etc. There's no specific guideline as to which medication to start, just that a patient who has epilepsy should be started on an anti-epileptic. I'd like you to contrast that with this case. A 57-year-old female is brought via EMS for altered mental status. She's noted to have several seizures in the emergency department, though her family says she has no history of seizures. She is noted to be febrile. The seizures are controlled with lorazepam. A non-contrast head CT is normal. What is the most appropriate next step of the options listed? MRI scan of the brain with and without contrast, a lumbar puncture, electroencephalogram, IV methylprednisolone, or intravenous tissue plasminogen activator. This is a patient who is seizing in the setting of a febrile illness with altered mental status. So of the options listed, the most appropriate next step would be a lumbar puncture. Adult patients do not have febrile seizures. Children can, from the ages of about 3 to about 6. You're not going to be expected to cover pediatrics for this examination. Adult patients who are febrile and seizing have a central nervous system infection, meningitis or encephalitis until proven otherwise. Of the options listed, an MRI scan would be appropriate, but the lumbar puncture should be done first. You already have head imaging, you have a CT scan that gives you the ability to do a lumbar puncture safely. So an MRI should eventually be done, but the lumbar puncture would be more important. An EEG also is appropriate, but not as appropriate as an emergent lumbar puncture. IV methylprednisolone and TPA are not indicated. This patient could be started on a treatment immediately, even before the LP is performed or the results are available, but of the available options, a lumbar puncture is the next most important step. So for central nervous system infections, any patient with altered mental status, seizures, and a fever should be assumed to have a central nervous system infection. Children can have simple febrile seizures, but not adults. Antibiotics and antivirals should be started before the lumbar puncture or confirmation of diagnosis. Similar to seizures, more important to treat first and then get information. Don't wait to get all the information before treating, because it can lead to a poor outcome for the patient. I included some basic CSF analysis for bacterial versus viral infections. What you'd be looking for in terms of a CNS process, a markedly elevated white blood cell count and markedly elevated protein can be consistent with infections of the central nervous system.